A functional dizziness assessment is really half examination and half alliance. Today, we're going to run the positive sign battery, screen for threat and avoidance, and actually weave cognitive techniques directly into the physiotherapy session itself. Welcome to part 2 of our Functional Dizziness Explainer series, designed specifically for you, the vestibular physiotherapist. We're going to transform those vague, overwhelming symptoms into crystal clear, actionable treatment plans. This explainer is based on the literature review, Functional Dizziness, Physiotherapy Approaches, Behavioural Assessment, Graded Exposure, and CBT Integration, published by Australian Dizziness Clinics. Available at australiandizzinessclinics.com. We're going to break down their incredible insights step by step. So here's the million-dollar question. What turns a vague, dizzy patient into a clear treatment plan? Well, it really comes down to this. 3 positive signs documented at session 1, paired with 1 genuinely good neurobiology conversation. That's the magic combo that makes the patient an active partner in their retraining. It's all about shifting the narrative from confusion to empowerment right out of the gate. Our roadmap for today is straightforward. We'll cover the positive sign battery, how to deliver the diagnosis, integrating CBT in your sessions, and finally, psychology referrals. Okay, section 1, the positive sign battery. Let's shift the paradigm. We are completely moving away from treating functional dizziness as a diagnosis of exclusion. You know, that frustrating, exhausting process of ruling out literally everything else. Instead, functional dizziness is now recognized as a positive sign clinical entity in its own right, and we want to actively run this battery right at the bedside. So, we start by looking for give-way weakness. Now, unlike structural organic weakness, functional give-way weakness shows this sudden collapse under load during muscle testing. But here's the wild part. Full normal strength miraculously returns when that exact same limb is recruited incidentally during a functional task. It's like a patient who can't lift their foot to a direct command, but then ambulates perfectly with absolutely zero foot drop. The collapse is inconsistent, and it doesn't follow any standard nerve distribution.
Next up in the battery, we've got midline crossing difficulty. Try asking a seated patient to touch your finger, then their nose, and then repeat it while crossing the body's midline, say right hand to left ear. A functional pattern will show a sudden hesitation. Maybe they abort the movement entirely, or they show disproportionate effort specifically right at that midline crossing. It's really fascinating because a structural issue, like cerebellar ataxia, produces uniform incoordination throughout the whole movement. But our functional patients, they experience a sudden block exactly at the midline.
Now, this next concept is absolutely crucial, distractibility. If you give your patient a competing cognitive task, maybe counting backwards from 107s or just keeping up a really deep conversation about something totally unrelated, you'll notice their functional tremor, sway, or unsteadiness diminishes. Sometimes it even vanishes completely. Why does this happen? Because the functional pattern requires conscious, top-down attention to remain present. By stripping away that top-down attention, you quite literally remove the sign. Structural disorders actually get worse under a dual task load, so this is just a brilliant differentiator for us. Functional tremor entrainment is another really cool concept to test for. When you're assessing a tremor, ask the patient to tap a specific rhythm with their other hand at a frequency that is completely different from their tremor. What happens? A functional tremor will actually entrain to that new rhythmic frequency, or it'll just pause mid-task. Parkinsonian or essential tremors won't do this at all. They maintain their own frequency because they rely on isolated oscillator circuits in the brain. Finally, we have the Hoover sign analog for the lower limb. So, with the patient supine, you place your hand right under their unaffected heel and ask them to lift the affected leg. In functional weakness, you'll feel absolutely no downward pressure from that unaffected heel. But when you ask them to lift the unaffected leg directly, boom, strong downward pressure returns instantly. This beautifully demonstrates the dissociation between their voluntary effort and their automatic motor system. And let me tell you, showing this positive physical sign to the patient is highly therapeutic. It actually proves to them that their automatic system works perfectly.
Section 2. Delivering the diagnosis. This is the very first step in cognitive rehabilitation.
Right, so now that we've gathered our positive signs, the way we communicate these findings to the patient isn't just a wrap-up chat. It is the first true treatment. You absolutely must open this conversation with the neurobiology rationale. And a quick rule of thumb, avoid the term psychogenic entirely. It just damages the therapeutic alliance. Instead, talk about the predictive coding mechanism. Explain that the brain generates predictions about sensory input all the time. But in functional dizziness, the predictive model is heavily biased toward expecting threat. It overweights internal somatic signals and underweights actual real-world sensory feedback. This system is miscalibrated, yes, but crucially, it is entirely retrainable. To really drive this home for them, use the traffic light analogy. It's like a malfunctioning red traffic light on a perfectly safe, completely open road. That red light causes hypervigilance and stops traffic, even though the road is totally clear. Fixing the light solves the problem. This is such a powerful analogy because it externalizes the misfiring system. It validates and legitimizes their very real symptoms while making it crystal clear that the software, their warning system, can absolutely be reprogrammed.
Section 3. Integrating CBT in sessions.
Once the patient is fully on board and understands their diagnosis, we don't just send them away to think about it. We immediately start weaving cognitive behavioral therapy principles right into our movement-based physical rehab. The absolute key here is how we deliver exposure. We have to use distraction-based exposure. Remember how distractibility reduced their symptoms during the assessment? We are using that exact mechanism for treatment. Listen, somatic-attention exercises, where the patient focuses deeply on their balance or their body, actually reinforce those maladaptive patterns. You want to avoid those. Instead, deliver exposure with their attention directed entirely away from the soma. Get them engaged in sports, dual-task activities, play some music, or just keep up a sustained conversation while they move.
Now, during these active tasks, if the patient does feel dizzy, that's your cue to step in and help with reframing catastrophic interpretations. When they feel that wave of dizziness hit, their brain's immediate, biased interpretation is usually, I am falling, I am in serious danger. You have to actively help them replace that catastrophic thought with the new, retrained system framing. Gently remind them, hey, that's just the malfunctioning traffic light. You are safe.
Section 4. Psychology Referrals. Knowing when to build a bigger team.
While we can, and absolutely should, weave cognitive techniques into our physio sessions, we've got to remain incredibly vigilant for clinical flags that exceed our scope of practice. If you identify significant comorbid trauma, dissociation, severe depression, or persistent severe avoidance, that is a clear trigger for action. You must refer them out to psychology or psychiatry. Do not try to continue physiotherapy in isolation here. The literature strongly shows that combined multidisciplinary care heavily outperforms physiotherapy alone in these more complex cohorts. At the end of the day, we want the absolute best outcome for the patient, and sometimes that just means bringing in more experts.
Let's quickly recap today's clinical journey. First, diagnose functional dizziness confidently using the positive sign battery, not as some exhausting diagnosis of exclusion. Second, deliver the neurobiology rationale and that traffic light analogy early and confidently to build a strong alliance. Third, lean hard into distraction-based exposure rather than traditional somatic exercises to retrain that predictive model. And finally, always know your limits and refer out to psychology when trauma or severe depression are in the mix.
So what comes next? Once you've got this baseline locked in, how do you actually progress the patient? In Part 3 of this explainer series, we build a graded exposure hierarchy, titrate symptom provocation, and dose habituation for durable change. We are going to look at the exact rules for when to push forward and when to back off. For additional resources, including the full literature review, the clinical cheat sheet, audio overviews, and the rest of this explainer series, visit AustralianDizzinessClinics.com. Please subscribe to the channel and leave a rating to support the series. Thanks for hanging out and decoding the complexities of functional dizziness with me today. After all, if we can fundamentally rewire how the brain perceives threat, just imagine what else your patients are capable of achieving.